Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. In this case, we have a 7-day-old infant who is brought to the emergency room. He was born full term, normal spontaneous vaginal delivery with a birth weight of 3.1 kilograms. There are no prenatal or perinatal problems per mom. Over the past 2 days, he has been increasingly lethargic and has been feeding progressively more poorly. He has not urinated in the past 18 hours, and he has vomited once. Physical exam reveals a hypotonic infant who only modestly responds to stimulation. He has a mottled appearance. Vital signs reveal a temperature of 37.3, a respiratory rate of 72, a heart rate of 190, and blood pressure of 50/20. He does not visually focus. Pupils are reactive. He is tachypnic but moving air. His heart rate is regularly rapid. So in this case, we have a 7-day-old infant that is brought in with the symptoms as described. So let's figure out how we're going to approach this 7-day-old child. Based on the history, we need to think about one word that will describe the assessment of this patient. The patient is coming in with hypotonia and lethargy and a mottled appearance. So what's the one word that you're going to use to describe this patient's overall assessment? You might say this patient is ill appearing. You might say this patient is toxic, and those would all be correct. But there's one word that I want to use that we can then create a differential diagnosis for based on that one word assessment. So what is that one word? That this is a 7-day-old infant coming in shock. That's the word I want to use to create differential diagnosis based on this 7-day-old infant coming in shock. The patient has poor urine output, the patient is lethargic, the patient is hypotonic and mottled, and that all shows that there's poor perfusion and this patient is in shock. One teaching point I want to make is about the word mottled. The word mottled is a very loaded word, and it really implies poor perfusion to the skin. In newborns, there's actually a diagnosis that newborns can have in which they appear mottled, and that could be a normal finding. And that is called cutis marmorata. And that basically happens when a newborn is exposed to a cold environment and they have vasoconstriction of their skin and they have this mottled appearance, and that's called cutis marmorata, and that could be normal. But in other infants, when you use the word mottled, that really implies poor perfusion. It implies that there's vasoconstriction of the skin and the skin appears kind of reticular or marbled in appearance. And again, that implies poor perfusion to the skin and overall poor perfusion. So that patient is in shock. So this patient, the 7-day-old, given the symptoms that we have, is coming in shock. And I want to talk about the differential diagnosis of a 7-day-old coming in shock. So there are 3 things on the differential that have to be immediately on the top of your differential for a 7-day-old coming in shock. Number 1 on that differential is going to be sepsis. When a child comes in, a 7-day-old comes in shock, the first thing you have to think about, and the number 1 thing on your differential diagnosis, is sepsis. Number 2 on the differential is also sepsis. And number 3 is also sepsis. When a 7-day-old infant comes in shock, that patient is sepsis, sepsis, sepsis until proven otherwise. And you need to think about the different types of organisms that are going to cause sepsis in this patient. And before we continue with the differential diagnosis, I want to talk about how you would approach a 7-day-old infant in shock that you think might have sepsis or shock for any other reason. And that is going to be talking about the A, B, C, D, and E. as the approach for this patient. So let's talk about those findings. So A, B, C, D, and E. So when a 7-day-old infant comes into shock, A, as many are probably aware, would be the airway. And the question is, are you going to intubate this patient that is coming in shock? A 7-day-old infant who has poor perfusion and who is in shock, it would not be a bad idea to intubate this patient so you can take control of their airway and be able to ventilate them and oxygenate them appropriately. So you might consider intubating this patient. B is breathing. So again, taking over the breathing of this infant can help when they are in shock. C is circulation. So you're going to get access to this IV access for this patient. Now in a 7-day-old infant, it actually might be very difficult to get a peripheral IV when they have poor perfusion. So you can try to get a peripheral IV, but if you're not able to, then you need to go to other access, and many times we'll do intraosseous or an IO to gain access. An IO you can use just like an IV, where you can draw blood, you can draw labs, you can give fluids, give medications. So getting a good access is going to be important right away when you identify a patient in shock, a 1-week-old in shock. D is drugs that you would administer for a patient who is in shock. And in this type of patient, a 7-day-old coming in shock, as we said, the top 3 things are sepsis, sepsis, sepsis. So the drugs that you might consider using on this type of patient are going to be IV antibiotics on this type of a patient. In this age group, you think about group B strep, you think about E. coli, and you think about other organisms like listeria. And then you could think about other viral type of processes like herpes. So different antibiotics that you might consider using in this newborn period could include ampicillin and gentamicin. And if you think about herpes as a cause, then you might give IV acyclovir as well. In addition to medication, antibiotics as a medication, the other drugs that you might give to help with circulation could be inotropic support. So you might give meds to help with circulation, so dopamine, dobutamine, and other type of inotropic support to help with circulation. So that could be another thing that you would do as well. And then there's another D that we're going to get to related to drugs kind of as we go through the differential diagnosis then. So again, 7-day-old coming in shock as described in this case. Sepsis, sepsis, sepsis until proven otherwise. Other things on differential, as you move down, the next thing on the differential many times is cardiac. You have to think about cardiac causes of shock in a 7-day-old. So we can talk about those. So cardiac causes. And there's different type of cardiac shock that a 7-day-old can come in with. They could just have some sort of rhythm issue. Where they have a fast rhythm or a slow rhythm, right? They could have a bradycardia, and one teaching point that comes up for boards and other questions is a mom who has lupus and the infant is born, potentially could have a 3rd-degree heart block, and that might cause bradycardia, and that can cause cardiogenic shock. So there could be rhythm issues from slow rhythms, or there could be rhythm issues from fast rhythms. So you can have the bradycardia, or you can have tachycardia related to things like SVT, Wolff-Parkinson-White syndrome, and VTAC. There's many things that can give you increased rhythm as well. So again, we said there could be bradycardia, or there could be tachycardia, and tachycardia can again be a part of SVT, WPW, it could be VTAC. And one thing related to VTAC, a teaching point related to VTAC, is that you can have increased or prolonged QT interval, and prolonged QT can lead to VTAC. And one teaching point that comes up related to boards and other clinical scenarios is that you can have congenital causes of prolonged QT syndrome. There's two common ones that we think about, and the way to differentiate those congenital causes of prolonged QT are related to hearing and hearing loss. So there's two congenital prolonged QT syndromes to think about. One is called Romano-Ward syndrome, and the other one is called Jervell-Lange-Nielsen syndrome. Romano-Ward has normal hearing, and Jervell-Lange-Nielsen has hearing loss. And those are both congenital prolonged QT syndrome. So a lot of times the boards and other tests will ask to differentiate those, and the key point to remember is that Romano-Ward has normal hearing, and Jervell-Lange-Nielsen has hearing loss, and that help differentiate. So that's just a side teaching point for that. Other cardiac causes could be related to kind of myopathic type of issues, where you have cardiac muscle type of issues, and this could be related to like a viral myocarditis or cardiomyopathy, but it also could be related to different genetic causes and like glycogen storage disease, especially like Pompe's disease, glycogen storage disease type 2, or other things like carnitine deficiency. So there's different things that can cause that. So we'll say glycogen storage disease, especially type 2, or Pompe's disease can give you cardiac cause of cardiogenic shock, and myopathic causes related to that. And then under cardiac, the other big area is going to be related to what happens at 7 days of age physiologically to the heart of an infant. We know around 7 days of age is when, and potentially before this, is when the ductus arteriosus starts to close, and by around 7 days of age, the ductus has completely closed, and any type of ductal dependent lesion that was still allowing perfusion distally because the ductus was open can present at 1 week of age in shock, because now the ductus is closed and now the child is having no systemic perfusion. So many times at this age is when ductal dependent lesions will present in cardiogenic shock around 1 week of age. So so ductal dependent lesions are a major consideration in this age group, presenting at this age, ductal dependent lesions, and there's three big ones that you have to think about at this age, at this time. So one is going to be a coarctation of the aorta. So you have a narrowing kind of distally from the outlet of the aorta, and you have the coarctation, and it's a ductal dependent lesion. So once the ductus closes, then you have no systemic perfusion, and that patient comes in shock. And then if you come a little more proximal to the coarctation, other things you can have is just severe aortic stenosis. So you can have aortic valve stenosis that can present this way as well. Again, distal and systemic perfusion is related to an open ductus, and once the ductus closes, then they can come in shock. And the third one that you have to think about is hypoplastic left heart syndrome, where you have a left ventricle that is hypoplastic, so cannot really provide systemic perfusion, and needs the ductus to be open to get blood supply from the right side of the heart. And once that ductus closes, that patient can come in shock as well. So I think the ductal dependent lesions like coarctation, aortic stenosis, hypoplastic left heart syndrome, I think are crucial to think about as part of the differential diagnosis. Okay, so now let's move on to another part of the differential diagnosis after cardiac. The next system to consider will be neuro. So there's different neurologic causes of shock in a 7-day-old, and that can include having seizures. So this patient could have had a seizure, it could be post-ictal, and presenting with hypotonia and lethargy. Other things could include an intracranial hemorrhage. So any type of bleed into the brain could cause these type of symptoms in this type of a patient. Now these intracranial hemorrhages, they could be spontaneous, but it also could be related to some sort of trauma. So abuse, shaken baby, things like that can also cause intracranial hemorrhage as well. So a 7-day-old coming in with shock, you have to think about some sort of neurologic cause and maybe some abuse and inflicted trauma or shaken baby syndrome. I think that is a a major consideration to think about as well. And then after neuro, another category that I think is very important to consider that we'll put in this area right here is going to be metabolic type of causes. So a lot of inborn errors of metabolism and metabolic causes can present at 7 days of age in shock. So we can kind of lump those all together. And I think one of the biggest ones to think about is going to be a male infant that is coming in at 7 days of age in shock and turns out to have hyponatremia, hyperkalemia, hypoglycemia, and acidosis. When a child presents with those type of electrolyte findings at 1 week of age in shock, one of the big things to consider in this category is going to be CAH, or congenital adrenal hyperplasia. And that can many times present at 1 week of age, especially in male infants. In females, you might pick it up earlier because females will be virilized and might have ambiguous genitalia, so they will present earlier and you might pick it up before they go into shock. But male infants who are already virilized will many times come in at around 1 week of age, presenting in shock after they have cortisol deficiency and hypoglycemia and electrolyte type of abnormality. So I think this is a huge consideration, is this congenital adrenal hyperplasia. And then there's other metabolic things, the different organic acidemias, the different amino acid defects, urea cycle defects, other things that can give you other electrolyte abnormalities. So there's a lot of those different type of acidemias that can present in this age group as well. All of these, and the CAH especially, something considered is going to be hypoglycemia at this age, presenting with hypotonia and lethargy and shock-like type of picture, where you have hypoglycemia secondary to things like CAH. So I think that's a huge consideration. And other electrolyte abnormalities. So again, you can have low sodium, you can have a high potassium, and then again, we mentioned the glucose and other electrolyte abnormalities based on the different acidemias that you might have. So I think those are some main considerations that you have to think about on the differential for this type of patient. And maybe one or two other type of categories that you might think about include GI causes. So sometimes GI causes can present with shock as well. One of the main things is going to be a milk protein intolerance. So sometimes kids can have severe milk protein intolerance, and they can come in with severe diarrhea and dehydration, and might have shock and things. In premature babies, maybe not as much in full term, but you might think about necrotizing enterocolitis, or you could also think about other type of obstructions like partial malrotation or a volvulus, where they have a bowel obstruction and peritonitis and come in shock as well. So I think those are things to think about as well. So we'll just say malrotation can present this way many times as well then. So I think those are some of the other things to think about. So again, I think these are the different diagnoses you have to think about on your differential when a 7-day-old comes in shock. And now with this differential, let's go back and complete our A, B, C, D, and E in light of the discussion that we've just had. So the other D to think about as far as giving medications that would be helpful, or also kind of checking labs, we'll call it dextrose. So it's so important when a 7-day-old infant comes in shock is to check their sugar, check their blood sugar, because they are at risk for hypoglycemia for various reasons, and then you might have to administer dextrose to those patients to help them with their symptoms. So that's part of the D. And then from the E, there's a couple of different E's that we're going to talk about based on this differential diagnosis. So sticking to the theme of dextrose and hypoglycemia, and in this category here, the other E that is important is going to be the electrolytes. So that would be the first E, would be checking electrolytes on your patient to help you come up with CAH or other electrolyte abnormalities. And then the other E is going to be all related to cardiac. So when you think about this differential diagnosis related to cardiac, then that helps you come up with your other E's that you would do on a patient coming in with 1 week old with shock. So that other E could be an EKG or an echo. Because you want to, again, assess for rhythm issues, and then you want to see if they have a ductal-dependent lesion, and getting an echo on that patient will be very, very important. And then the last E is also kind of related to that. If the echo does show a ductal-dependent lesion, then you want to try to keep the ductus open in order to maintain peripheral and systemic perfusion. In order to do that, then the E is related to a medication that could be given to help keep the ductus open. And that medication, as many might remember, is prostaglandin E. So you will give prostaglandin E to help keep the ductus open if you think the patient might have a ductal-dependent lesion in this category. So that's part of the E and the treatment and the initial approach to a patient with shock and possible cardiac causes of shock. So this is the differential diagnosis for a 7-day-old shock based on the case that is presented. These are the things that we're worried about. And then this was the initial approach, the A, B, C, D, and E, to help you assess the patient and help treat the patient. And our patient actually turned out to have a coarctation of the aorta when this patient presented. They had an echo, and the patient was found to have coarctation as a cause of the 7-day-old presenting in shock. But it's important to keep all this in mind as you are thinking about the differential diagnosis and the approach to a patient coming in at 1 week of age in shock.